in oligometastasis appears to be very interesting, and I'm looking forward to this kind of interaction. And again, as I said, a very happy New Year. And I also note that this is our Zoom, our own, this time platform. So many more things to come up. And thanks to Dr. Raghunath and Dr. Ginil for having this new platform come up for us. So we are truly independent, I must say. With these remarks, I would request you to proceed. Thank you very much.
Thank you very much, sir, for the opening remarks. And now, I think in between, if Dr. Mehta joins, we'll put him on board. But we'll start with Dr. Gagan Gautam. He doesn't need any introduction. He's senior consultant uro-oncology at the Max group of hospitals, Max Healthcare. So he'll be talking about 3D printing as an aid for partial nephrectomy. Over to you, Dr. Gagan.
Thank you very much, sir. This is indeed a very exciting meeting today because of the amazing topics that are there. And I'm very grateful to you for having given me this topic, which actually made me learn a lot about the stuff which I didn't know much about. So here are my disclosures. To start off, I think before we get into the role of 3D printing as far as partial nephrectomy or nephron sparing surgery is concerned, let's just take a brief overview about what 3D printing really is and what does it really mean when we say that some object was 3D printed. And I found somebody on the internet, on YouTube, who seems to know much more about this than I do. So I'll just play a 2-minute video here, which will give us a brief of the 3D printing process. I think you should be able to hear the audio of the video as well. In case there's any problem, please let me know.
3D printing technology is already changing the way we produce objects, from tools and toys to clothing and even body parts. 3D printing is part of a process known as additive manufacturing, where an object is created by adding material layer by layer. Additive manufacturing allows designers to create complex parts for machines, airplanes, and cars at a fraction of the cost and time of standard means like forging, molding, and sculpting. Now, smaller, consumer-friendly 3D printers are bringing additive manufacturing to homes and businesses. The first step in 3D printing is to create a blueprint of the object you want to print. You can use modeling software like Blender to create your own designs, or you can visit websites like Thingiverse or Shapeways to find objects other users have 3D modeled. Once you have a finished design, it's time to send it to the printer. Some printers, like the MakerBot Replicator 2, have renewable bioplastic spooled in the back of the device, almost like a string. When the printer receives the data, it pulls the material through a tube, melts it, and deposits it to the plate where it instantly cools. As you can see, the 3D object is created through layering, where the printer will add one layer of the object at a time until you have a fully formed structure. The most common material used in 3D printing is plastic. But the use of some other materials allow for the creation of some pretty amazing products beyond simple tools and toys. 3D printing food is becoming very popular, and additive manufacturing has allowed for the creation of some pretty intricate treats. In the medical world, doctors are testing biomaterials for regenerative medicine. By using a patient's cells, doctors could 3D print small body parts like ears and noses. Some surgeons have even tested 3D printed organs for transplants. Recently, giant 3D printers in China printed 10 houses in just one day and at a cost of less than $5,000 per house, proving just how cost and time-efficient 3D printing can be.
Right, so this is something which gives us a little bit of an overview about what 3D printing really is and how is it actually done. When you talk about the role of 3D printing in urology itself, or if you look at it in terms of medicine or surgery, the interest in 3D printing has really gone skywards in the recent years. And in fact, now every year there are more than 2,000 articles being published on PubMed on 3D printing in the medical field. So very clearly, this is something that is there for the future. So how does 3D printing really work? You take a two-dimensional structure like you would see in a CT scan or an MRI, and you segment that area using different colors and different color coding. So you have a separate segmentation for the kidney, for the tumor, for the vein and the artery. And by doing this segmentation, what you're basically doing is you're creating a three-dimensional model within with the software, which can later be transferred to a three-dimensional to a 3D printer and used to create these models, which help in which are exact replica of what you see on the CT scan or the MRI. Of course, there are different types of 3D printing methods. There is really no point in going into the details of each of them, but just to know that the most common type of the 3D printing is the FDM, which is the fusion deposition modeling, and which uses this thermoplastic material like you've seen in the video here. Of course, other ways of 3D printing are also there. Powder bed fusion printing uses a binder or a laser to fuse the powder that is deposited through the printer. And the most common one is the SLA or lithography, which allows you to print using a laser to harden a liquid resin layer, which is deposited layer by layer. So overall, there are more than one techniques which are used, and that is why there is a plethora of different 3D printing techniques and the different printers here.
Hello, join.
Of course, when you use the powder method, then there is the final model that comes out is very intricate. You have multiple different colors and which replicates the anatomy very well. But this is made almost like a ceramic, so it's very easily breakable and may not be a durable model. This is the SLA printer, which uses a single color resin to carve out the tumor and the kidney in this particular case. So broadly speaking, you can use 3D printing in medicine and in urology to look at to print medical products and equipments which can be used in surgical procedures, prosthetics, implants, used for making anatomical models of various structures in the body, which can help in surgical planning and education. And you can even use tissue and biomaterials, which is of course at a nascent stage. We have 3D printed skin and cartilage. Now, of course, in the future, one may dream of making entire organs through 3D printing, but we are far away from that particular point as of now. When you come to specific utility in nephron sparing surgery, you can look at three broad headings. One is education, training, and surgical planning, which can be implemented by using 3D printed models of kidney and tumor for a partial nephrectomy. In education, this particular technique has been used for training medical students, and it has been found that those medical students who are given the models, the 3D printed models of the kidney and the tumor, can do a much more accurate job of doing the renal scoring or the renal nephrometry scoring with the 3D models as compared to a two-dimensional structure, such as two-dimensional investigation like a CT scan or an MRI. Moreover, it has also been seen that this tool has also been used for patient education. And this is a study which was published recently, and it was found that when the 3D printed models of the kidney and the tumor were shown to the patients prior to their surgical procedure, and they were asked to fill out a questionnaire before being shown the model and after being shown the model, there was a significant improvement in various aspects of understanding of the patient, which included understanding of the basic kidney physiology, anatomy, disease and tumor characteristics, and understanding of the surgical procedure as such. So it helped in better prognostication, better counseling regarding the surgical procedure, and gave more confidence to the patients as such. When you look at the other aspects of 3D printing in nephron sparing surgery, one of the really exciting alternatives to in the training of surgeons that is coming up is actually use of an inanimate 3D printed model, where you have hollow tubes which represent the vasculature and the pelvic calyceal system. And using these 3D printed models of the kidney, the tumor, and these hollow tubes which are actually perfused with artificial blood, one can practice a robotic or laparoscopic, or for that matter, an open partial nephrectomy without even going into the patient or without the utilization of animal models instead by way of using these kind of 3D printed models. So when you actually go ahead and give this incision on this 3D printed kidney, which is made up of polyvinyl alcohol, there's actual bleeding which occurs, and you can use the sliding clip rhinography technique. You can actually measure the blood loss, the warm ischemia time, and moreover, you can also practice doing an intraoperative ultrasound, which is able to show the tumor within this 3D printed model, and enables you to get an idea about the surgical margins and the edges. And if you have the tumor walls made up of a potentially fluorescent dye, then you can even look whether there has been a positive surgical margin in the remaining specimen after trying this out. So this provides, and this has been tested in a multi-institutional setting. And this paper was also published last year in BJU International, and has been found to add significantly to the surgeon's confidence in being able to plan the procedure and in being able to replicate the procedure in the patient, and also to be able to identify what are the weak points in their surgical steps and how to correct them. And this has, in this particular study, has been has demonstrated a clear difference between expert surgeons who have done more than 150 robotic upper tract surgeries versus novice surgeons who have done less than 30. And there is a clear difference in various parameters, including warm ischemia time, estimated blood loss, and overall console time in the patients when in the models when they have been operated by expert surgeons versus novice surgeons. Moreover, this is also correlated well with the GEARS, which is the global evaluative assessment score for robotic skills, and that has been found to be significantly different and correlated with these models between expert and novice surgeons. When you talk about surgical planning, that is to have
a couple of minutes.
This is the last slide, sir. I'm done. So when you talk about surgical planning as such, one of the really good studies that have come recently have actually come from India, from Dr. Rishi Nair from All India Institute of Medical Sciences, and the other residents and faculty in All India Institute of Medical Sciences, where they have actually created inanimate models of the kidney and the tumor for a number of patients prior to taking them up for a partial nephrectomy. And then using a Likert score analysis, they have analyzed via a questionnaire whether this particular model adds to the value of doing a partial nephrectomy after the initial creation of the model. So it has been found that it is has a very realistic resemblance and dimensions as compared to the actual partial nephrectomy specimen. It helps in orienting the surgeon with regards to the direction and depths of the cuts when you do a partial nephrectomy. It is also better appreciated as compared to patients. One can appreciate the anatomy better as compared to a triple phase CT. And moreover, it helps in preoperative surgical understanding and planning. So as a result, the surgical planning and safety of the surgery may be enhanced by using 3D printed model prior to doing the actual surgery, although in real time data is lacking with regards to whether it actually makes a difference in the surgical outcomes in patients, and those are studies which are still undergoing. So to conclude, I think we are in a stage where 3D printing is still at an initial stage when it comes to medicine, and it will be something which will be something to look forward to. And there may be a time within the next 10 years, 15 years, where this is really going to explode in a big way, not only in terms of medical equipment manufacturing, but also in terms of actually resulting in creation of organs for transplants, and also almost eliminating the need of animal models for surgical training, with excellent simulation facilities available which provide a real-time experience to a surgeon to practice his or her surgery before he or she actually goes onto the table. Thank you very much for this opportunity. It's really wonderful to be a part of this program.
So thank you, Gagan, for clearing the concepts regarding the 3D printing for partial nephrectomy. So as we started late, I think we'll quickly go on to the uh, next topic. Incidentally, Dr. Mehta has joined. So I think we'll take him on after this, because this is the second part of the nephrectomy series. So this is the virtual 3D reconstruction as an aid for partial nephrectomy. And this will be by Dr. Raghavan, who's a senior uro-oncologist at the Apollo Hospitals, Chennai. Over to you, Dr. Raghavan.
Thank you so much, sir. Thank you, Kulkarni sir, and my extremely good friend Gagan. Nice to catch up with all of you online. So Gagan nicely put a case or a situation about the 3D printing. Here I'm going to talk about the virtual 3D modeling. So we all know that we just skip these slides because we all know that partial nephrectomy is the standard. To a fantastic CT scan is an essential component before we do a partial nephrectomy. But once that is done, as Gagan nicely put it, there are difficulties for a surgeon, especially understanding the depth, how much of cut, where to do, how much of kidney has to be mobilized, and so on and so forth, especially when it comes to the complex partial nephrectomies. And that's exactly where the 3D modeling comes. As Gagan nicely put it, 3D model in a printed version genuinely improves the surgeon's comfort as well as the patient's understanding of what they are going to handle or what they are going to face as a surgery. It is also very useful for trainees. Now, the same thing without printing it in an obvious way, if we can do it in a virtual model in any platform, be it in a laptop or a mobile phone or a pad, then that is virtual 3D modeling. It is an interactive 3D modeling, and you can understand how good where the tumor is, how to rotate the kidney, where is the depth of the tumor, what is its relationship. You can remove the tumor and see what it is going to deal with, such as the arteries and the veins that are going to come forward, and so on and so forth. So planning becomes very easy with an interactive 3D model. Now I'm going to I should confess that Inner Sight Labs is what I use. I've been using it for the last nearly 4 months. We have done 21 cases using the Inner Sight Labs technology. And therefore, what I'm showing is going to be Inner Sight Labs work. And that's what I'm using. I'm going to share exactly that. The advantage of 3D modeling, as Gagan put it, first, you are much better in your decision about incision. Where exactly you're going to do, especially how much of kidney can be spared, and so that you don't take much of it. So renal parenchymal preservation becomes part and parcel of 3D recon as well, especially when you're planning to do zero ischemia. I don't do it, but for who zero ischemia is something they practice, this becomes important. Hilar anatomy. Many times we think, oh, there is one artery and the other artery is not very sure. These are the places where you exactly you find how many arteries, how many veins, where are the origins, insertion, is it an early branching? All those information comes very clearly in these models. Personally, in the last 20 cases, I have realized my operating time, the overall operating time, has come down by at least 17 to 20 minutes. We are doing a study collecting all the data for those patients. We thought, let us finish another 10 more before we write it up as the study. It has been done by Shirk et al., where 92 patients have been assessed, and they found that the operative time was reduced, clamp time reduced, blood loss is reduced, and the length of hospital stay reduced as well. Of course, without going to say, 3D model helps so much in patient education, surgeon education, and the trainee education. So I'm going to run past a few case scenarios. This is a 26-year-old who had this mass. As you can see, the green one is the tumor. It is located bang on the hilum. And what we did is that we did a 3D model, understood how much of kidney will be preserved, what is the vascular anatomy before we did a surgery for him. I was concerned about this anatomy, so I chose to do an open surgery for him. And I should confess that we managed to save the kidney nicely. And at 3 months of follow-up, the patient has a fully functioning kidney, as much as the cortex that was left was functioning without any problem. And that, I believe, was because of the 3D model. Exactly the artery that was arching on the tumor, we could identify, we could save, we could identify all the calyceal anatomy. And because we did an open operation, cooled the kidney and managed to soothe each and every calyceal system. So this is about the hilar anatomy. This is the picture, intraoperative picture. Exactly, you can see what you saw in the 3D model is what you see in the real time. And that is a tumor that was taken out with clear margin, grade 1. The second case is a small tumor outside in a patient who has every comorbidity that you can ever think of. And therefore, we want to keep the operating time as low as we could. We did a 3D model. We realized that she has an extremely complex arterial and vascular anatomy. So what we did is that we just did a partial nephrectomy. Operating time was 1 hour 10 minutes because we just went straight in, found that artery, lower polar artery, found the upper polar artery, removed the tumor and came out. This patient was a classical example of how much the operating time could be reduced because of the 3D model. There was no searching involved at all. We know exactly where the artery and veins are, and exactly that's where we went and found it. And the tumor, just to show that whatever you see, you can see the 3D model on the right side and the real-time surgery on the left side. You could see that exactly what you see in the 3D model is what you see in the real time as well. The third case is a large interpolar tumor occupying almost the whole of the anterior cortex with a single artery and vein. I was very worried whether I can get an anatomical closure, a secondary renography would be possible or not possible, and whether I have to sacrifice the kidney. After doing the 3D model, I thought there was a reasonable kidney to preserve. So we decided to go. See, this clearly showed what is the calyceal anatomy, what is the arterial anatomy, where is its situation, how many calyx I will be opening, and whether I need to put a stent or not. All the anatomy which I want to know beforehand, I got it by the 3D model. So we went ahead and did the surgery. I left the cavity open because I thought it was too big for me to close. So I did a good 1-layer renography and came out. The other thing is that you could see very clearly that there was so much of toxic fat. And because of the 3D model, I know exactly where the tumor will be. And I could, did not waste time in mobilizing a lot of kidney and just went ahead and did the surgery. The last patient is a patient of BHL, 37-year-old. When I saw the CT scan, I said, let's get rid of the kidney. It's not going to save. But after doing a 3D recon, I thought, let me give it a try. Probably I may be able to save it. Didn't make any promises. And I said to the patient that we will try and do an open surgery. Once again, gives me the time to cool the kidney and work patiently with the tumor. So that is a 3D model which clearly shows the complexity of the tumor that we are dealing with. This is because it's not a robotic surgery, I have to give you the pictures. That is the relationship of the tumor to the kidney, and you can see that the kidney is exactly same as the 3D model. After the tumor is removed, the next picture shows whatever is left there. That's exactly what you find inside. And that is the last picture which shows that whatever you saw in the 3D is exactly what you see in the real time as well. With the chair's permission, I'm going to share another real-time 3D model. Here it is. Can you all see that? So what I wanted to show is that it is very interactive. You can move the tumor in any direction. You can interact with it by removing the tumor and then understand what is going to be found inside. And then you can remove the kidney and then place the tumor back and say, that is the artery that I know to clip. So it really helps in zero ischemia surgeries if somebody wants to use it. And you can remove the vein, that is an early branching. So you can see that, I need to go and hold the artery quite low down, and there is a second artery as well. Such interactiveness is what the virtual 3D model gives. With that, Chair, I conclude to say that 3D modeling is extremely useful in partial nephrectomy, be it the printed model or the virtual model. And I think that will be the future for any partial nephrectomy. Thank you so much.
Thank you, Dr. Raghavan, for being crisp and on time. And I think we go on to the next speaker. Next speaker is Dr. Anurag Mehta. He's the Director of Pathology at Rajiv Gandhi Cancer Institute and Research Center. And he'll be talking on a very hot topic, that is the newer biomarkers in RCC. Over to you, sir.
So thank you, Vineet, and good evening all. I will speak to you on newer biomarkers in renal cell carcinoma. As a matter of fact, I have spoken in the same forum once before also, and I think this will be a repetition for some, though I have tried to buff it up a bit. So actually speaking, in renal cell carcinoma, all the biomarkers are recent ones or the newer ones because they have been discovered only in the last 1 decade. The story of the renal cell carcinoma actually started in 1952 when the WHO classified it into 2 categories of clear cell renal cell carcinoma and granular cell renal cell carcinomas. But over a period of nearly 6 decades, it has now been classified into 50 entities, and many of which have been molecularly defined, and they also include inherited RCCs. But despite these advances in clinical practice, we continue to separate RCCs into just 2 broad categories of clear cell renal cell carcinomas and non-clear cell renal cell carcinomas. And this is actually unfortunate in the sense that it has acted as an impediment to understand the biology of non-clear cell renal cell carcinomas and develop effective therapy for advanced renal cell carcinomas. So we need to change. And what are the changes that we need to undertake? We need to diagnose the RCC histologically into better separations and maybe assisted by molecular characterization. For example, this is a clear cell renal cell carcinoma, but this could be driven by VHL or TCAB1 or maybe by MITF translocations. Similarly, a renal cell unclassifiable may be L-rearranged, and therefore it is necessary to find out what is the basic driver in these renal cell carcinomas, because that is prognostically and therapeutically important. And then we also need to have biomarkers to identify the group of patients who will have poor outcomes so that we can focus on preventive recurrences. And we know 40% of the cases who had undergone successful resection can have recurrences. So we need to find out who will recur, and we need to identify the inherited cancer better because we do a hash of it. We really speaking make no effort to try inherited cancers. And we should also, after having identified the inherited cancer, make a better effort to diagnose the predisposed, the mutation carriers in the kindred of the proband. And we also need to improve the efficacy of treatment in advanced renal cell carcinoma by matching treatment to biomarkers. So let's see what we can do here. So renal cell carcinoma is actually a very heterogeneous category. There are about 50 entities, as I said earlier, and many of these have been molecularly defined. They are basically identified by the genetic alterations they harbor. But fortunately, there are surrogate IHCs available for them, except for TCEB1 mutated RCC, and they can be used to identify these cancers and then carry out the molecular identification of the offending genes. And concealed within this classification or within these diagnostic entities are inherited renal cell carcinomas. For example, von Hippel-Lindau syndrome in clear cell renal cell carcinomas, type 1 hereditary papillary renal cell carcinoma in type 1 papillary carcinomas, some cases of hereditary leiomyomatosis with renal cell carcinomas are concealed within the fumarate hydrate deficient RCCs, and the Bart-Hawk, Dubé, and succinate dehydrogenase deficient RCCs are virtually always inherited cancers. And we need to identify them because they make up a substantial percentage of RCCs, about 5 to 8% of these. So let's see how we can use surrogate IHC and the molecular diagnosis to find the predisposed, as well as identify these categories of tumors which are defined by their molecular biomarkers. So for example, here is a case of a renal cell carcinoma. On initial microscopy, it looked like a papillary type 2 renal cell carcinoma. The nuclei were somewhat characteristic of a particular alterations, and we carried out fumarate hydratase IHC staining. The fumarate hydratase was deficient, and its corresponding oncometabolite was present in the tumor cells. So this was a case of a fumarate hydratase deficient RCC and not a case of papillary renal cell carcinoma. And this has its own implication. This has an implication that this could be an inherited carcinoma. So a germline testing is required. And if this proband is found positive, then we need to carry out the testing of the kindred. Similarly, another case of a succinate dehydrogenase deficient renal cell carcinoma. The IHC gave us the initial clue that this could be deficient in succinate dehydrogenase, and subsequently the germline testing is done to identify the loss of succinate dehydrogenase activity. So these are the categories of inherited renal cell carcinomas: von Hippel-Lindau, hereditary leiomyomatosis with renal cell carcinomas, hereditary papillary renal cell carcinoma, Bart-Hawk-Dubé syndrome, BAP1 tumor predisposition syndrome, and succinate dehydrogenase subunit related RCCs. The genes are given here in the red letters. So one will need to test these for germline mutations to identify the particular inherited cancer. And who shall be tested? All those patients of RCC who are less than 46 years of age, who have bilateral and multicentric tumors, or who have been detected on IHC screen to carry out fumarate hydratase, folliculin, or succinate dehydrogenase deficiency. And these are the genes that should be tested dependent upon the morphology. But my suggestion is that we can now, in the days of when the NGS has become cheap, can actually test all of these genes together. So this is our first encounter with the newer biomarkers, where we can, using an NGS panel, identify the inherited cancer in this category of patients. And likewise, we can also test in the in the somatic setting for TFEB, and then confirm the TFEB presence by FISH, and this can help us in identify the MITF translocated RCCs. And talking about the renal cell carcinoma unclassifiable, we have a recently defined category of ALK rearranged tumors, and this can only be identified by doing the genomic IHC or by doing fluorescent in situ hybridization. So in a way, this is a new biomarker, and this is important to identify these cases, because when treated with ALK specific tyrosine kinase inhibitors, profound and prolonged responses have been seen in these cases. Now, now coming to papillary renal cell carcinomas, we know that papillary renal cell carcinomas are classified as per WHO classification into type 1 and 2, but many uropathologists will tell you that they can't neatly fit all cases into type 1 and type 2 papillary RCCs. So there are papillary RCCs NOS, about 30 to 40%, and there is a recently defined category of oncocytic papillary renal cell carcinoma. And these four categories are prognostically very, very different. So while oncocytic papillary renal cell carcinoma has virtually 100% survival, the type 1 also has a good survival, but type 2 papillary renal cell carcinoma have bad survival, while the papillary renal cell carcinoma NOS has intermediate survival, and therefore they need to be identified distinctively. And the transcriptomic and proteomic examination of the papillary renal cell carcinoma, we have found that using a combination of 3 antibodies and ATP binding cassette C2, GATA3, and carbonic anhydrase we can actually clearly separate these and align them with the prognosis. So the newer biomarker as far as the diagnosis and finding the inherited cancer is concerned, the newer biomarkers support the diagnosis in 5 to 10% cases of renal cell carcinomas. And we can also identify the patients who need to undergo germline testing. And then we can spread this testing to the kindred to find the predisposed. And the genomic IHC of ATP binding cassette, C2, carbonic anhydrase, and GATA3 can actually help us separate papillary renal cell carcinoma into prognostically significant categories. And then now we come to the putative roles of biomarker in forecasting the prognosis, and I will talk about clear cell carcinoma and papillary renal cell carcinoma. So we all know that the hallmark change of clear cell renal cell carcinoma is inactivating mutations in the VHL gene, and about 70% of the patients of clear cell renal cell carcinoma have biallelic inactivation of the VHL gene, while about 20% have monoallelic inactivation, and around 10% of the cases of clear cell renal cell carcinoma have a VHL wild type. That means it does not have a mutation. And this is a significant event in terms of survival. So it has been seen that the patients who have no VHL inactivation, that means they are wild type of, they have a wild type of VHL, or those who have a monoallelic VHL inactivation, they have a high grade clear cell renal cell carcinoma, mostly with sarcomatoid morphology, with high Fuhrman grade, with heavy infiltration of inflammatory cells, and a strong staining for VEGF. And as far as the survival is concerned, it is seen that the VHL wild type and VHL monoallelic inactivation type has a far inferior outcome compared to those who have a biallelic VHL inactivation. And the upcoming classification of WHO proposes to classify clear cell renal cell carcinoma into those which are VHL altered and those which are VHL unaltered types. And there will be a need to separate this category of clear cell renal cell carcinomas from the mimickers like clear cell papillary renal cell carcinoma with leiomyomatous stroma, and so on and so forth. So VHL inactivation is going to become a very important prognostic marker as well as a diagnostic characteristic of a clear cell renal cell carcinomas. So, but the VHL inactivation can initiate the tumor, but additional mutations or genetic alterations are required to promote the tumor growth. And for this purpose, there are 10 or 11 genes which undergo alterations. Of them, these in the blue, navy blue circles, the PBRM1, which is mutated in 30 to 50% of the cases, BAP1 mutated in 5 to 15% of the cases, KDM5Cs and SAT-D2 are important. These are all chromatin remodeling genes. In addition, TP53 is also important. Now, what is the prognostic implication of these additional mutations? So it has been seen that we know that VHL inactivation is a prognostic marker for good outcome. In addition, PBRM1, BAP1, and TP53 have been correlated with the prognosis. So how does it correlate with the prognosis? So it has been seen in Mayo College study that those who were PBRM1 inactivated had far better survival compared to those who were BAP1 mutated in all patients with all stages, all comers. And the PBRM1 inactivated have a median OS of around 10.6 years, while those which were BAP1 inactivated had a median survival of 4.6 years. And similar findings were reaffirmed in the TCGA study. Now, looking at the early renal cell carcinoma, again, it was seen that those who are BAP1 inactivated have a far inferior outcome compared to those who are BAP1 wild type. And this this is beyond the S-sign score, which is used to prognosticate in cases of early renal cell carcinoma. And similarly, in the advanced renal cell carcinoma, it has also been seen that those which are TP53 inactivated, BAP1 inactivated, BAP1 inactivated have far poorer outcome compared to those who are wild type, but reverse is the case with the PBRM1. The PBRM1 inactivated have a superior survival compared to those who are PBRM1 inactivated. So this genetic alterations have now been included as a part of MSKCC scoring to improve the concordance index of MSKCC scoring for advanced renal cell carcinomas. So a unifying concept will be that there are two types of clear cell renal cell carcinomas, those which have a VHL monodriver or which are PBRM1 inactivated. They have an attenuated progression, and even if when they have a metastasis, it is usually to the lung, and it is a very, very indolent kind of a disease. And this metastasis, this disease languishes for years, while there is another group of clear cell renal cell carcinoma, which can be either VHL wild type or which are BAP1 driven or which have multiple alterations, and they have a rapid progression and metastasis to many sites. So coming to the papillary renal cell carcinoma, the pan-omics studies of papillary renal cell carcinomas have shown that
couple of minutes, sir.
Yes, couple of minutes, I'm finishing. So has shown that there are three clusters of papillary renal cell carcinomas. The cluster 1 is similar to papillary renal cell carcinoma type 1 and the cluster 2 to type 2. But there is another cluster of papillary renal cell carcinoma, which has a very dismal prognosis which is worst in all the RCCs. And this is characterized by CpG island methylation of several genes, including CDKN2A and fumarate hydratase. And by doing simple IHC for fumarate hydratase and a P16, one can identify this subset of papillary renal cell carcinoma who shall actually, who have an appalling prognosis and may probably need to have a different type of therapy than currently available. And the papillary renal cell carcinoma 1 and 2 can also be separated by looking at lead family of microRNA. In PRCC1, there is a diverse expression of lead family of microRNA, while in PRCC2, all the family members expression is raised at least 10-fold or more. So in prognostic workup, clear cell carcinoma, BAP1 has a bad prognosis, TP53 has a bad prognosis, at least in metastatic disease, and PBRM1 confers good prognosis both in early as well as in the advanced disease. And in papillary renal cell carcinoma, absence of immunostaining for P16 and fumarate hydratase identifies a subset of papillary renal cell carcinoma with the CpG island methylator, which has an appalling prognosis. And now coming to the role of biomarkers in selection of a therapy for advanced renal cell carcinoma. So we use VEGF inhibitors and ICI plus VEGF inhibitors and combinations of 2 ICI. So let's see, are there any predictive markers for VEGF targeted therapies? It has been seen that the clear cell renal cell carcinomas with PBRM1 mutation have a significantly are actually the better responder compared to those who have no PBRM1 inactivation. And this finding has been confirmed in the iMotion 150, where those with the PBRM1 inactivation had 16-month PFS advantage over those who were PBRM wild type. And same thing has been confirmed in the post hoc analysis of recorder and COMPARS cohorts. And it was also seen that those with KDM5C inactivated RCCs have very good prognosis, very good median progression-free survival with sunitinib. Similarly, the tumors with the high angiogenic signatures also do well with VEGF TKIs. Are there any predictive marker for immune checkpoint inhibitors? Truly speaking, none. Unlike in other cancers, nothing works. No TMB, no PDL1, no tumor indel burden, no inflamed phenotype. So is there anything that works? So it has been seen again that those who are PBRM1 inactivated have higher numbers of patients with clinical benefit and some modest benefit in the PFS as well as in the OS. And it has been seen that those patients who have a hot tumor, inflamed tumor, unexpectedly do worse with the PDL1 inhibition compared to those who do not. And this is because these tumors have an alteration which is 9p deletion, and 9p deletion is inversely related to PBRM1 inactivation. So PBRM1 inactivation confers response to and better PFS with the immune checkpoint inhibitor, while inflamed tumors with del9 confers a poor prognosis and poor outcomes. So is there any predictive marker for MET? None so far. So we will give a go to this slide. So to summarize, PBRM1 activation in clear cell renal cell carcinoma predicts response to VEGFR TKI and immune checkpoint blockade, and is inversely related to the presence of T effector cells and del19. High angiogenic signatures predict response to TKIs. T effector high and angiogenesis low expressor benefit from immune checkpoint blockade. KDM5C is a strong predictive marker for prolonged benefit from sunitinib. And despite MET alteration being common, the papillary renal cell carcinoma, it has not been found actionable. None of the biomarkers are prospective validation till date. And it is my belief that it may be helpful to test for VHL, PBRM1, BAP1, SAT-D2, KDM5C, TCEB, and TP53 in clear cell renal cell carcinoma for prognostication and therapy selection. And the good labs can have a germline panel of VHL, SDHC, fumarate hydratase, BAP1, TSC, TSC2, MAT, folliculin, and P10 to identify inherited renal cell carcinomas. So thank you so much for your patience. I finish. If there are any questions, I will be happy to answer.
Thank you so much, sir. We still have a long way to go as far as the biomarkers are concerned in RCC, because there are no specific biomarkers per se. So in the interest of time, I think we'll go to the next topic, which is small renal masses, SBRT, how to go about it. And this will be dealt by Dr. Vedant Murthy, who's a professor of radiation oncology at TMH Mumbai. Over to you, Vedant.
Thank you, sir. Good evening, everybody. This is a very exciting and a very interesting talk. As far as I am concerned, it's very exciting, and I hope it will be interesting for you, because this may throw light on something new that you may or may not be aware of as far as radiotherapy is concerned. And unlike a typical radiation oncology talk, I'll not get all technical on you. I have only about 8 minutes. So I'll try to answer 4 questions that I think are may be of interest to most of the urology audience. Why are we talking about RCC and SBRT now? Is it any good for primary treatment in terms of efficacy and toxicity, and what do the guidelines say about it? After doing SBRT, what happens to the cancer, that is the kidney mass, and what happens to the kidney itself? And where can we fit in it in your practice? These are the things that I'll try to touch. So the problem with RCC and RT has always been radio resistance. This has been known for the last 30-40 years from cell line studies. And over the last 4 decades, conventional radiotherapy has really failed to make any impact in kidney cancer, and as a result is currently used only as has been used as a palliative treatment. But things have changed. Something tremendous has happened with the availability of certain technologies. of ablative SBRT-like radiation in the recent years, where we can deliver a very high dose per fraction, 10 or 15 gray per fraction to the kidney. That has shown improved outcomes, as I'll show you, and the paradigm is moving towards definitive treatment in kidney cancer. So let us see what happened. And again, I'm not an expert at this. What is the biology? So with normal radiation, 2 to 3 gray per fraction radiation, there are two ways of cell kill generally. One is a direct tumor damage. You can see here in red. That causes cell death and a response. This is with any cancer. And there's also a mechanism by which endothelial apoptosis takes place, which causes microvascular dysfunction. But at normal fractionation, HIF1 overexpression happens, and that releases VEGF and beta FGF, which block this endothelial dysfunction. But with very high dose radiation, that first mechanism remains, but the HIF1 alpha mechanism, that doesn't take place, and that inhibition doesn't take place. As a result, there is a downstream cascade, and in addition to the normal tumor damage, there is microvascular dysfunction that leads to the ability of radiation at these very high doses to affect tumor kill. So there is a lot of data on efficacy, and I have just to ease everybody for lack of time, I have just put this excellent systematic review, so many studies, and you can see these are all small studies over the last 10 years. The local control rates with SBRT is to the tune of 97 to 100%. So that's a really high local control. And does that come at a cost of significant toxicity? So this is the toxicity data, and I have put here severe toxicity, grade 3 as we call it. It's barely in the range of 1 to 2%. So clearly this is a safe treatment and it's effective for local control. That has actually led to the guidelines getting changed most recently. This was not there in the 2021 NCCN guidelines. We now have a mention of SBRT for small kidney masses with a category 2B recommendation in NCCN. In fact, EAU 2021, EAU is generally much slower to bring in radiotherapy changes, but that also recommends SBRT as one of the treatment for this these kind of cancers. So where does it fit in? I'm sure all of you can identify patients who may be in your practice, who may be one of these. So they may be medically inoperable, they may have comorbidities. In fact, what Dr. Raghavan showed in his wonderful presentation on 3D Recon, the case number 2 had several comorbidities, small tumor, perfect for SBRT. Patients may refuse surgery. Sometimes it may be slightly large, and this is an important point because RFA and other ablative therapies may not be really effective, or you may need multiple settings for a larger tumors, T1B tumors. Sometimes both kidneys are clearly options that one can think of. I'll show you 2 pieces of evidence to back up what I'm saying. This is a very nice sounding name called IROC Consortium. They got together a number of centers who have treated SBRT to kidney. They looked at 81 patients with SBRT to a solitary kidney. I know NSS can be done, but it may or may not always be possible. At 2 years, the local control rate was 98%. And the mean GFR decrease in that single kidney was about 5 to 6 ml per minute. So, and not a single patient required dialysis. So that's quite interesting. In fact, about a quarter of the patient exhibited an increase in their GFR as a rebound. The second piece of information is for larger tumors, T1B, which means more than 4 centimeters. a diameter more than 4 centimeters. Again, you can see very few local failures, and this on the right shows you the change of GFR. Most of the times, GFR does drop by about 5 to 10, about 10%, but in a quarter of the patient, it actually increases. I'm not sure why that happens. Now, we monitor post-SBRT, we monitor two things. We monitor the kidney tumor and we monitor the GFR. It is important to understand that unlike squamous cancers or other cancers, these tumors do not respond in a classical way. They respond slowly over several years sometimes. In fact, initially, there may be a slight increase in the size of the tumor on radiology. You can see on the right an excellent representation of how this is MRI tumor size changes. It takes long time and often never goes down less than 50% in size. Renal function is monitored by GFR and creatinine. You can see most of the times it is very mild impairment or very mild decrease in the grade of renal impairment. So the remaining kidney can actually be saved. Now, what is the kind of technology we need to pull this off? We need things like good visualization of the tumor, good planning, delivery, image guidance, etc., etc. And while the theme of the meeting seems to be 3D, we actually end up doing 4D based planning. And that is actually taking care of the intrafraction motion to deliver such a high dose. This is a video, this is a cine-MR that we use for one of our patients. We monitor the motion of the kidney with breath and use that as a margin. So all this technical stuff, but we use this in practice. And who can do it? Do we need very, very advanced complex machines? No, these are advanced linear accelerators. Can your friendly neighborhood radiation oncologist actually do it? I think most can. Many of the centers, the big centers with modern linear accelerators and good image guidance can pull this off. You don't need any specific brand of machine, and we deliver about 40 to 50 gray in 3 to 5 fractions. You can see here a small lower pole tumor here. The plan is made, this is delivered, and after 6 months, there's a necrotic tumor that is still visible. It will not go recommended actually. I'll finally leave you with another very interesting indication for SBRT in kidney primary actually, that was published just a week or two weeks ago. This is for IVC thrombus, SBRT for small study as a proof of concept. And after about 2 years, there was about more than 50% of the patients had IVC thrombus recanalization, and there were not significant toxicities. So these are the things that SBRT can actually do in practice. So to summarize, it is a real option in many scenarios in clinical practice. It can be done on a modern regular linear accelerator with good image guidance. It is safe. I have shown you that. It is amenable for slightly larger tumors also. And the responses are slow but steady, and it should not be biopsied. And the normal kidney, the GFR drops by about 5 to 7 ml per minute over long term. Thank you so much.
Thank you, Vedant, for being crisp and to the point. And definitely the surgeons will have food for thought regarding the small masses. So let's switch gears now. Let us come to the metastatic setting. And I would invite Dr. Dev Narayan Datta from, he's a senior consultant radiation oncology from Amrita Cancer Center, Kochi, to speak on the oligomet part. Over to you, Dr. Dev.
Good evening. Thanks for the invitation. And it is a very exciting talk. And Dr. Vedant has already put the momentum. And few of the—
I think you can put it on the PPT mode, please.
Now it is getting seen.
Yes, please continue.
Yeah.
Yeah.
Now in SBRT for renal cell cancer metastasis, it is also a very interesting area, and something which we all need to think of. Now, we always know that renal cell cancers are radio-resistant. What is the role of SBRT in metastatic setting, which is a stage 4 setting, and what is the evidences with that, and what is the dose schedule, and what is the role of immunotherapy? That will be our talk for today. Now, we have in Amrita Institute a prospective database for oligometastasis from different sites. And we have target accrual is of 261 patients, and we have 200 odd patients we have accrued. In that, if you see the renal cell cancer with metastasis, it is around 17, means 8% of our patients are renal cell cancer patients. And if you see the all patient cohort, the actual overall survival is around 19 months. So you have a decent follow-up of all our patients. And among those 17 patients who are RCC with oligometastasis we have treated, 9 were brain metastasis, and 4 were lung, and 4 were bone metastasis, and 4 patients among those 17 expired in this follow-up, and all other patients are on follow-up. So 23% of the patients are expired, and 17% are alive at 16.8 months follow-up. What that shows that a group of patients is going to be alive at a decent follow-up, but many of the patients will have progression. So we can see that 83% of the patients have a new lesion in different areas. And among those 83% of the patients have progression, 65 patients have a new lesions in different part, in different organs. So in RCCs with metastasis, they live long, usually have new lesions in new areas, and that need to be always addressed. That is where SBRT comes into the picture, and that can actually help to have a local control and survival benefit as well. Now, if you see the overall survival and progression-free survival of this patient cohort, we can see this overall survival is very impressive. Estimated mean overall survival is on 28 months, whereas progression-free survival is only on 18.8 months. Means that many of the patients have a new lesions in some areas. They're alive, but need to be addressed again. That is where SBRT comes into the picture in RCC with metastasis. This is one of the case on 2018 we have treated with brain metastasis from RCCs, very small volume disease, 14 in single we have treated, and at 26 months follow-up, it has complete response. Similar, this is a bone metastasis, April 21 we have treated, and the patient has 8 months have a good response. This is a lung cancer, lung metastasis from RCC, 2020 we have treated in May. It has lesions small lesions in both the lungs, and we have treated both with 18 gray single fraction, and we can see at 18 months follow-up, right lung has a stable disease and left lung is a complete response. But many of these patients do have a new lesion in some other areas, and that had to be addressed with re-SBRT. Now, we always know that I was taught that RCC is a radio-resistant disease, and that has come from this old studies of post-RT and neoadjuvant radiations with a low dose of radiation, which has shown there's no benefit in terms of radiotherapy in RCCs, especially post-op setting. But this is why the SBRT is more critical in RCC. And as Dr. Vedang told the same thing, in conventional radiation, when you give a fractionated radiotherapy, it is a oxygen-dependent DNA damage and p53 radiated mutations. And that causes pro-angiogenic factor release. And problem with this pro-angiogenic factor release, which happens with conventional fractionation radiation, they actually can cause proliferation of the vascular endothelium. And the RCCs are mostly the vascular tumor, and it can actually progress. And that is why in conventional fractionation radiation, we don't see too much of response in RCCs. Whereas when you give SBRT, means more than 6 gray per fraction, this is a SMAs, which is translocations, and from a pro-apoptotic ceramide. And this ceramide kills the vascular tumors. And that is why with hypofractionated radiation with SBRT, we do see response in RCCs, whereas conventional fractionation, we don't see some response. Now, from proof of the pudding, this is a very interesting study. 50 patients with RCC with metastasis treated with SBRT, and 50 patients were treated with conventional fractionation radiations. And you can see the response, radiological response. SBRT has a far better response than conventional fractionation. That shows the hypothesis what is ceramide-based with symptom killing in RCC is true in clinical practice as well. Now, when we see the predictors of radiological response in multivariate analysis and from a meta-analysis for RCC with metastasis, you see more than 80 gray BD, there's a response. More than 9 gray per fractions, dose fraction, there is a response. So it shows that we have to give higher dose for fractions and higher dose of radiations, then there's a response to RCC in metastatic setting. Now, as Dr. Vedang has already told, there is a response, but there's a slow response, slow and steady response that happens. So if we have a short-term follow-up with RCC with metastasis, we may see a stable disease. But when we have a long-term follow-up, that time we can see a response, radiological response after the treatment. So a short-term follow-up data of a SBRT series may not show the actual results, but a long-term follow-up of the RCC series can show the response to treatment. Now about the dose escalation, there is an excellent dose escalation study in RCC with metastasis, 25 in 5 gray, one group 30 in 5, 135 in 5, 140 in 5. It has been seen that if we have 25 or 30 gray, then there is still a scope of improvement in local control. 35 and 5 has an optimal response. More than 40 gray has shown some complications. So 35 in 5 or equivalent dose, maybe this may be optimal in treating RCCs, and there is a dose response relationship with RCCs. Now, these are the RCC with lung metastasis, and very interesting thing, you can see the 6 to 7 odd patients, median follow-up of 28 months. 1 and 3 year local control is 98% and 92%. So is it any metastatic disease like RCC with the stage 4 disease, we can see a 1 year or 3 year of more than 90%. That is very encouraging with SBRT. In brain metastasis from RCC, we can see that it's a median overall survival of 14 months. We can see 1 year survival is around 57%. That is also quite impressive. And if you see this meta-analysis of small multiple series, and you see all the series from the lung metastases or abdominal metastases, bone metastases, 1 year and 2 year local control is 98, 97%, or 93, more than 90% local control at 1 year and 2 year. That is extremely impressive. And that shows that SBRT is useful in RCCs with metastasis. Now, the interesting thing is about immunotherapy along with SBRT. Now, it has shown that if you give SBRT followed by immunotherapy or TKIs, there is a much more response than otherwise. So there is an interesting study. There are a few studies similar, which have shown that if you give SBRT, that actually can affect the abscopal effect, and immunogenicity of RCCs is well known. That can be exploited with SBRT followed by immunotherapy, and the radiological response is much better compared to only SBRT or only immunotherapy. Now, if you see the dose, if it is 2.5 centimeter tumor, the median overall survival is around 92%, and 5 centimeter tumor, it is 26%. So if the tumor is larger, then the local control is less. So that also shows that higher dose of fractions if you give, or higher total dose if you can give, that has an impact in terms of local control and survival as well. So take home is RCC is radio sensitive. When you're giving higher dose of fraction, means more than 6 gray per fraction. Response to RT is slow but persistent. It takes years for radiological response. So we should have a long-term follow-up to establish any implications of any SBRT series. High dose radiation is immunogenic reactions. So SBRT followed by immunotherapy do have impact in terms of response to treatment. And in metastatic setting, there's abscopal effect. And with brain metastasis, in 1 year survival is around 70%, lung is 85%, bone 90%. And primary site, when you treat, as Dr. Vedang has already told, it is around 90% local control at 1 year. And if you see surgery versus SBRT in a metastatic RCC setting, is on 14 to 32 months of median overall survival with SBRT, whereas it is 10 to 14%, 14 months with metastatectomy. So hypofractionated SBRT is an effective method in treating the metastatic RCCs. And as Dr. Vedan has already told, that now the SBRT has come into the algorithm for in the treatment of RCC, especially in metastatic setting. Thank you.
Thank you, Dr. Datta. So initially, what was thought that radiation RCC is a radio-resistant tumor, but now that myth is being dissolved with the studies which you have discussed. So thank you so much once again. And now we will move on to the adjuvant treatment strategies in RCC, which will be dealt by Dr. Rajiv, who's a Senior Consultant Medical Oncologist at the Apollo Cancer Center, Chennai. Dr. Rajiv, please.
Good evening, sir, and thanks for the opportunity.
Rajiv, can you put it on PPT mode, please?
Yeah.
Fine, please continue.
Yeah. So my topic is RCC on adjuvant treatment strategies. So the overview which I'm going to give a talk is on the RCC recurrence and role of adjuvant therapy, and RCC recurrence risk definition and what are the strategies we have. And I will touch upon two agents which are practical for us. That is sunitinib, which is a TKI for adjuvant therapy, and the STRAC trial, which led to its approval. And of course, pembrolizumab, the new IO, which has got recent FDA approval, and the Keynote 564, which led to its approval and update. And finally, we will look at which patient subgroup will really benefit from adjuvant therapy and conclude. So if you look at the overview of the RCC, we will know that the RCC recurrence usually occur in the 5 years after the surgery, and approximately 30 to 50% of patients undergoing curative surgery can have recurrence, and it depends on the risk stratification. And the risk stratification we use can be varied, and we will see what will really look into the real risk of recurrence in our patients. So why we should look at this risk of recurrence and offer adjuvant therapy is because in a disease like RCC, the benefit of staying disease-free longer is beneficial for our patients, and also practical, because once we have a recurrent disease, it is lifelong treatment. And also the opportunity as far as RCC is concerned, as we saw in the pathologist talk also, a lot of advances. So the patient may even get a chance of getting a new drug if we can delay the recurrence. We know that once we have a high-risk RCC recurrence, then the recurrence-free survival itself is less compared to a low-risk disease. So if you look at the high-risk recurrence, the recurrence-free survival is less than 1 year, and that is a problem for most of our patients. So how do we look at risk score and define the RCC risk of recurrence? Usually what we do is very descriptive, localized, loco-regional, and metastatic. Most of us will look into TNM staging and look at whether they are T3, T4, which is usually high risk, and also a grade of the tumor, and also the node positivity, of course, is very high risk. The UCLA, the ISS scoring system, which takes care of the TNM as well as the Fuhrman grading, as well as the performance status, is a very practical scoring system for us to know the risk of recurrence, and many of the adjuvant studies have looked into it. And also we have the SSIGN scoring, which look at the site and the size and the grade and the necrosis. Of course, the next level, as seen in the pathology talk, is to look at molecular level and looking at risk recurrence scoring like we do for prostate and breast cancer, but that's not yet got into practical use. So if you look at the UCLA ISS scoring, and it provides 5-year prognosis using TNM staging based on the Fuhrman grade and performance status and the TNM stage. So any nodal disease which is positive, that is become very high risk. T3, T4 is high risk. Grade 3, grade 4 is high risk. And anybody who is in ECOG more than 1 is also considered as poor risk. So this is how practically we look at the risk of recurrence and offer adjuvant treatment for our patients. Now, when we look at the adjuvant therapy, we will be after the surgery, it will be only a subset of patients finally who will go for adjuvant therapy, and most of them would be into the surveillance or watchful waiting. And whom to choose for adjuvant therapy is a concern for uro-oncologist as well as the medical oncologist. And why is it important? Because many of the time you have seen that in other sites like breast cancer and colorectal cancer, adjuvant chemotherapy is standard of care. And many of the biologicals like anti-angiogenic agent, for example, bevacizumab, works very well in colorectal cancer in the metastatic setting. But when they did trials in the adjuvant setting, we really can't extrapolate that to the adjuvant setting, and to surprise, many of the colorectal and breast cancer trials were negative for all these biologicals. So just because our IOs and TKIs work well in the metastatic setting, same holds good for our renal cell cancer. Whether it will work in the adjuvant setting, we need real robust data before it becomes standard of care. So if you look at the newer generation study, which looked at the adjuvant tyrosine kinase inhibitor, the oral VEGF and was the TKIs, the ASSURE trial was for sorafenib, the ESTRAC trial, which led to the approval of sunitinib. Then we had PROTECT trial for pazopanib, ATLAS trial for axitinib, and the sorafenib, which was SOurce trial, and everolimus trial, Everest. Disappointingly, majority of these trials had mixed results, and most of them were negative, except some of the outliers like ESTRAC, which had a positive trial, which we will look into a bit details later. So when we looked at the newer generation IO, that is the immuno-oncology drugs, you have the PROSPER, which is a new adjuvant as well as adjuvant nivolumab. Initial data is exciting. Then we have the adjuvant atezolizumab. And of course, the keynote trial 564, which has led to the approval of pembrolizumab, and the checkmate, which is adjuvant nivolumab and ipilimumab. This combination, we know that is approved in metastatic. So whether it works better, we will know by the checkmate 914 trial. And of course, RAMPAT trial, which looks at durvalumab and tremelimumab. So most of these trials are expected in the next 2 or 3 years, and I'm sure we will have interesting data coming up. When you look at the sunitinib data, the trials, the FDA actually approved after the ESTRAC trial in patients with high risk RCC after nephrectomy. And the NCCN right now also recommends sunitinib in a high risk stage 3 category, but it is a category 3 recommendation, and we'll come to what happened there. So if you look at the ESTRAC data for sunitinib in the adjuvant setting, you can see that the patients who had adjuvant treatment was patients who had a clear cell RCC, and they were real high risk patients in the ESTRAC group, that is more than T3 or node positive patients. And they were stratified based on the UCLA risk stratification and the performance status. The randomization was simple and well conducted. The sunitinib was given in the classical 50 mg per day, 4 weeks on, 2 weeks of schedule for 1 year. Now that is a practical challenge which I'll be discussing later. The primary endpoint of the study was DFS by the Central Review Committee, and of course the secondary endpoints was overall survival. The ESTRAC had more than 60% of their patients as high risk at baseline, unlike the pembrolizumab, which had more of high intermediate, and also they were only clear cell histology. So this is to be kept in mind when we discuss options with our patient. The primary endpoint was sort of met. Median DFS was significantly better at 6.8 years with sunitinib with a high p-value, and also a 24% risk reduction. And that way, there was a risk reduction of 24% of patient developing a second cancer or death. More patients were disease-free at 5 years with sunitinib. This was with placebo, and the 59.3% was the disease-free survival at 5 years compared to 51.3% for the placebo. Now, which were the subset which really benefited? I think this is what practically we should be looking at. Patient who was ECOG PS0. So excellent performance status, young patients is one we should be selecting for sunitinib if at all we are giving. And also there were patients who were T3, high T3 and T4 or any N1 had the maximum benefit, and grade 3 and grade 4. So the real high risk clear cell RCC with excellent performance status is the patients who benefited from the S-track strategy. Now this I think would be the most important slide that I'm projecting. This is the S-track side effects data. We see that it is a real struggle to give 1 year of this drug in the classical schedule, that is the 4 weeks on, 2 weeks off schedule, because majority of the patients will develop diarrhea, hand-foot syndrome, hypertension, fatigue, nausea, weight loss, mucositis. So most of the patients, up to 40% of the patients in the trial itself has dose reduced, and majority would not be able to complete the prescribed dose. So this is one thing we need to be explaining to our patient before we put in the adjuvant setup, because in the metastatic setting, from the physician as well as the patient side, there will be a tolerance to toxicity, but in an adjuvant setting, it is very difficult to deal with this toxicity for 1 year. The summary was that more than 60% of patients at high risk was in the S-track population, and sunitinib did improve the DFS, but unfortunately there was no significant improvement in the overall survival. And the subgroup which really benefited was patients with excellent performance status, the real high risk, and the grade 3 and grade 4. Now we come to the adjuvant pembrolizumab, that is the keynote 564 data. So this trial was in the pretext that majority of the VEGF and the other TKIs had mixed results, and that's when they thought of trying the IO, which was sort of getting good results in the metastatic setting. Here, two things, patients had a risk of recurrence based on the TNM as well as the grading, and also the one unmet need was patients who had oligometastatic disease, that is M1 stage, with who has undergone primary surgery as well as metastatectomy, that is M1 NED. We have shown that TKIs do not work in that setting. There is no improvement in survival, and the plan was only surveillance. This group was added in this pembrolizumab study group. Again, the study design was quite straightforward. Histologically confirmed clear cell renal cell carcinoma, randomization within 12 weeks, and tissue sample was sent for PDL1 assessment. The stratification was interesting, which was between M0 versus M1 NED, that is stage 4, which has been fully resected, and also M0 group with the PS. And the pembrolizumab, the drug was given as a 200 mg IV infusion, flat dose infusion every 3 weeks for 1 year. This will come to around 17 doses in 1 year. And the primary endpoint they looked was DFS as per investigator assessment. And the key secondary endpoint was the overall survival, and other secondary endpoint, of course, was the safety. The baseline characteristics here were slightly different from the S-track population. We had intermediate to high risk as the 86%, and the real high risk was only 8%. And we had around 6% of the patients who were M1 NED. But another interesting factor is they had included patients with sarcomatoid features. So we had almost 11% of the patients who had sarcomatoid features included in the Pembro study. So if we are deciding on patients with sarcomatoid features, this is the agent to choose, because the S-track clearly had no sarcomatoid features included in their trial arm. So if you look at the DFS here, it was very impressive. If you look at the hazard ratio of 0.68 with the p-value of 0.001, the 24 months DFS rate was 85 versus 77 for pembrolizumab versus the placebo. And if you look at by the subgroup, irrespective of the PDL1 status and the performance status, it has worked. And the highest benefit was, although the numbers were small, as I showed, in around 6%, but then M1 NED has the excellent response and had a very high benefit. So if you look at the overall survival, there is a trend. You can see the curves really separating. But as per the melanoma data we got in melanoma, the OS benefit only after 5 to 8 years of follow-up. So we need to be patient and wait for the follow-up, but it is hopeful that we may have a positive overall survival with pembrolizumab. But we need now the data is too early for us to look at overall survival. If you look at the safety aspect, compared to sunitinib, it is reasonably safe. But then we need to look at fatigue, diarrhea, and rash again compared to grade 3 or 4. and also all the immune related side effects like hypothyroidism, pneumonitis, adrenal insufficiency, diabetes. Sometimes we may need to use steroids if there is grade 3 side effects. But fortunately, there were no treatment related deaths in almost 1,000 patients they had enrolled in this trial, which is sort of reassuring. So they concluded that adjuvant pembrolizumab post-nephrectomy demonstrated a statistically significant and a clinically meaningful improvement in DFS in patients with intermediate high risk, and M1 NED. Additional follow-up is needed for the secondary endpoint of overall survival. And the safety results were in line with other IO, which we usually use in the other subset. So this was the first positive phase 3 trial with a checkpoint inhibitor, and the authors suggested that this should be the new standard of care, and thereafter it got the FDA and as well as the EMA approval. Last 2 weeks back in the ASCO GU 2022, the key author presented their 30 months update, that is 6 more months later. You can see very interesting data coming out. Again, the M1 NED, which is that really the curves are separating, and even in the sarcomatoid features. So probably this is the subset which will drive the benefit for this agent. So if you have M1 NED or sarcomatoid patients, then this agent should be really discussed because it is clearly showing benefit. So how do we finally select patients for adjuvant therapy? As I suggested, it is usually the risk stratification. And if you have a STRAC-based risk stratification, it is either T3, T4 or node positive. And if you have pembrolizumab as the agent in mind, then you can add sarcomatoid, T2, G4 and M1 NED in addition to the other high-risk subset. What does the guideline say? It says we can use adjuvant pembrolizumab as per NCCN for grade 4 stage 2 as well as from stage 3. And the approval for sunitinib is there for high risk stage 3, but you can say that it is category 3. So we need to discuss this with our patients. The ESMO or the European group, which is more conservative, again has come up positively with the pembrolizumab data, and they have given an addendum in 2021 saying that we should consider pembrolizumab, but they have gone on to discuss that we should discuss with our patient that the overall survival data is not mature, and we need to tell the potential long-term adverse events of immunotherapy with the patient before we offer. And it can be an option for stage 4 NED disease also. As far as the sunitinib is concerned, it does not have a EMA or the ESMO approval. So concluding, RCC recurrence is a reality, and we know that the recurrence-free survival in a high-risk patient is low. So the first hit is the best hit, as we say in most of our patients. We should use validated risk score to define the risk of recurrence. The adjuvant therapy is really evolving. Now we know that we have 2 agents for use. The more solid data is for pembrolizumab, but then 1 year, and the cost is really a concern. And if at all we are going to use it, it should be definitely in sarcomatoid histology and also in stage 4 NED, where it is really making a difference, and also in other high risk. Whereas if you at all you are using sunitinib, it is to be used with caution. It should be an excellent performance status patient, real high risk, only clear cell histology, and again keeping in mind that it is a category 3 recommendation. Thank you.
Thank you very much, Dr. Rajiv, for getting an insight into the adjuvant treatment, which is the new exciting vista as far as the RCC is concerned. So, Dr. Raghunath, there is some problem with 3 or 4 of the panelists joining. Dr. Amit, Dr. Swarupa, Dr. Raimon are not able to join. So shall we conclude it here, because incomplete panel will be a problem? Dr. Raghunath, are you there? Whenever there is a technical glitch, it is a big glitch. It cannot be sorted out. There was a problem for the faculty to join and probably it has not been. Dr. Raghunath, are you there? Or Samreen?
Can't see him. He was there.
Yeah, he was there. He was probably trying to get the panelists on board because
Your moderator has not joined. No? Moderator Amit
yeah,
Rotam or
the
Amit
moderator
Joshi?
and two panelists.
Yeah, I am there, sir.
I saw
Reed.
Joshi. Yeah, I saw Joshi.
Yeah, I am there, sir. I have joined since 7
Amit
o'clock.
is there.
Yeah, I know.
Chandan is
I
there,
saw
and,
Joshi.
Alok
I saw
is there.
Joshi.
But
No, who is the moderator?
moderator is Amit Rotan. He is not able to join. Dr. Srupa is not able to join. Dr. Ravi Mohan is not able to join.
Oh my God.
So,
I also had problem, but I could sort this
yeah,
out.
I also had problem. I was only audio this thing, but somehow was able to. So I think if that is the case, I would request Dr. Rawal
To conclude, yeah.
conclude and wrap
Or
up,
you can
the
ask some
proceedings.
question, Vineet. At least Rakesh is there, Amit Joshi is there. You can ask 2-3
Well,
questions. We do have 10 minutes time or 20 minutes time.
Probably we can have we can discuss ourselves. We whoever is not there, we can substitute.
If you don't ask, can I ask a question from you?
Yeah, sure.
Okay.
You can.
Tell me, where will you use in adjuvant setting? I don't think that sunitinib is a drug of choice because it does have side effects, but pembrolizumab, the data are very strong.
So,
but then
Rajiv, are you there?
Rajiv, I think he's
Yeah,
gone.
Rajiv is there. Rajiv?
Yes, sir.
Yeah. So you see, sunitinib, the problem is a lot of side effects. You make asymptomatic patient to a symptomatic phase, and you have it's not an innocent drug. But pembrolizumab, as the data has come, and what will be your approach in your practice, not as what the trial says in your practice? Where would you like to give it?
Yeah, I think practically the challenge is the financial toxicity with pembrolizumab because we need to be aware that we need to give at least for 17 cycles, and with the best of support, even if you get would be around 35 lakhs of rupees, which is not easy. So from the science point of view, it is definitely useful. I would try to push for a patient if they are financially okay for sarcomatoid features. I would definitely use for patients who are T3 and above, and patients who are node positive, and stage 4 NED. That is, if you have a oligometastatic disease and you have resected. Earlier, we were not using sunitinib because it was a negative data in such a situation. So I think a young patient with really high risk, if they have deep pockets, we should be discussing that.
What my feeling is, yes, sir, you wanted to say something?
Yeah, I just wanted to ask him, what about neoadjuvant setting in pembrolizumab?
I think as I just mentioned in the talk, it's not yet approved, but we have the neoadjuvant nivolumab, ipilimumab data, earlier data, which has been presented, which is very exciting. So it's only a matter of time. I think it will come into the neoadjuvant setting, whether it is IO or IO plus TKI, because we have data for axitinib plus avelumab also presented in the ASCO GU recently. But then it has to go through the full approval before we can suggest to our patient. But yes, maybe in the next 6 to 8 months itself, I think we'll have mature data coming for the neoadjuvant. But right now, the approval is for adjuvant.
In neoadjuvant, cabozantinib actually has got very good results among all these drugs.
No, but yet come into
the data are there right now, but it's not in the practice. My feeling is that why do we give 11 months?
1 year.
Yeah, why don't we give for just 6 doses? As are we giving in adjuvant setting as a chemotherapy? We give 6 doses. So maybe in future we can probably have that information. Because
So
it's 11
that's a
months
very
is a huge.
practical way of thinking it, sir. Even if it is 3 doses work, we would be happy to give only 3 doses. But, what happens is, even if we extrapolate from metastatic RCC, we have seen that the prolonged responses happen only if you give for 12 months and more. So the data was there initially for using for 24 months, and then the curve really flattens out. And you can, earlier the recommendation was you can stop at 24 months, and then it came down to 12 months. So I'm sure the data will be generated, but right now we don't have enough data to tell that whether the 6 cycles will be enough. If it is a negative trial, we will be unnecessarily wasting patients' resources for even the 6 cycles. It is better to observe and use it in the stage 4 setting, where we know that it will definitely work, rather than give for 6 cycles. That would be my take as of now.
I was in GUSCO, and the person who spoke on this, he said he will only give this drug to very high risk patient for recurrence.
Absolutely, absolutely.
Like node positive and sarcomatoid variety. These are 2 situations where
Now,
it probably
another question comes. This is posed to the surgeons. We always talk of a deferred cytoreductive nephrectomy, and that is gaining vogue. So, any comments on that?
I think, Joe, that
sir,
trial
I need to ask a question, sir. Chandan,
yeah, Chandan,
medical
after
oncology.
this, you can ask.
Sir, for the surgeons, so recently the clear trial with pembrolizumab and lenvatinib having the highest response rate, it's around 71%. And do you still feel in the clear low risk IMDC surgery is still the options, surgery is still an options? So previously used to have sunitinib, right? The response rate is around 30%. So now you have a combination which giving you the response rate of 71%.
No, in metastatic setting?
Yes, metastatic setting. Sorry.
So, will you give such a costly drug for how many cycles you have to give?
17.
No, sir, I'm setting. If you don't have the money problem is there, if somebody want to, are you planning to do surgery also?
No, definitely. If the patient, there are definite indications. Now, Amit has come. Amit Rotam has joined. There is definite indication for surgery. It's not and it cannot be offered to everyone. That is one thing. Now, coming back, like a big kidney tumor with a single metastasis, will you offer the target therapy or lenvatinib and
I think, sir, we'll let Amit do the proceeding, dream it, and the logo is pretty good. So, Amit, finally you made it.
I'm very sorry. Oh my gosh, today was an expedition.
Excellent. So I think you can pose, single question to each of the panelists, and then probably we can wrap it up. So you can ask Amit, you can ask Alok, you can ask Chandan, you can ask Rakesh. All of them are there.
Right. Right.
Yeah.
So just questions directly, right? Slides required?
But my video is not visible. Can you make it actually?
I think
this actually stopped from your side.
Do it verbally now.
Okay.
We can have a open house kind of a discussion. Anybody who wants to pitch in can pitch in.
Right. So I think, so my thoughts were more on, initially was adjuvant therapy now has come. So I was actually trying to show one of the
adjuvant we have discussed. So I think
so that's
can
over,
over
right?
to the metastatic side. Yeah.
Perfect. So metastatic, then my thoughts were choosing IO versus IO TKI was the first question, was the major the first step decision. So maybe anyone can start off. I'm sorry, I think half of it has been covered, so it's very difficult to know.
I think Amit, you can take it.
So can you repeat the question?
So metastatic immuno plus immuno versus immuno plus TKI, I think this debate still goes on. But two things were the second part of the question was immuno plus TKI. Now, after 1.5 years, which immuno and which TKI have you sort of made a decision in your mind?
Yes. So I think what the things what we have learned over the years, one thing is that if the patient is very much symptomatic, I think in that scenario, practically IO plus IO is, we know that it will take time to work. So in those patients, practically in day-to-day setting, and that we have seen in our practice, the patient presenting with a large liver metastasis, rapidly accumulating pleural effusion, and we have started IO plus IO. Then after say after 2 or 3 cycles, patient is not responding, and then we have to change. And when we change, we see the clear-cut response. So from that point of view, it is clear that high volume disease go for a combination of IO plus TKI. Which IO plus TKI, that is the matter of debate. So if you see the experience, I think most of us have used Pembro plus XZ in most of the patient. We know the toxicity, we know how to manage those toxicities. In few patients, when we use at least my experience of using Pembro plus lenvatinib, it seems to be little bit, at least with the 20 mg doses, the Pembro plus len is little bit hard on the patient. So I generally start with either 16 or 18 and then gradually build up the dose, because if the toxicity happens, then the patient stops the treatment and we don't know whether the Pembro is causing the problem or lenva is causing the problem. So from that point of view, Pembro plus XC, we have more experience. And regarding the Cabo plus Nevo, I have not used only in 1 or 2 patient. So from the disease point of view, if the data suggests that if there is more of a bony metastasis, we may prefer Cabo, because there is some data in the palliative second line that cabozantinib may work better in the patient who have a bony metastasis. From that point of view, patient who present with a liver metastasis, there is some indirect suggestion that Pembro-Len may be a better alternative. But I think at the end of the day, the company which is providing the best patient assistance program, if we get as that will be preferred, because the difference is not that much. So among 3 IO plus TKI, which one is better? That data is more mature for the Pembro XZ, and the among IO plus TKI and IO plus IO, definitely the IO plus IO have the most long-term follow-up. So if a CR, we are looking for a CR, then and patient is not very much symptomatic, lung-only disease, I may prefer IO plus IO in that scenario.
Okay, so I think IO. So my only thought was Pembro Axi, though we should not be doing 3 comparator trials of IO TKI, but we are sort of I'm leaning towards moving away from Pembro Axi at least, because response rates clearly difference, PFS difference. Though we keep saying we should not compare them cross trials, but I don't know, the Lenva and the Cabo data is much more stronger. I kind of have switched off from Axi as my drug of choice, especially in patients which we think are fit enough to tolerate it. I don't know. I think whatever the others, they also are thinking all 3 are same, or do you think they are different?
Dr. Rajendra is there.
Alok, you can.
Alok.
So, I mean, over time and whatever limited experience I have of using combinations, I have recently become more comfortable in using cabozantinib with nivolumab as far as the tolerance is concerned. Earlier, Pembro plus exitinib was the option, the combination option. But beyond these 2 options, I have, I mean, I have not used IO-IO combination or a Lenva plus Pembro combination. So these 2, that is Pembro plus exitinib or nivolumab plus cabozantinib. And recently, since the availability of the generic cabozantinib, we are leaning more towards using this combination. And the data, as we know, the cross-trial comparison, Nivo-Cabo data appears to be promising, a bit more promising.
Yeah, So I know this is a difficult kind of, it's like if you have experience, then they say go with what your experience is best with, and we have had longest experience with Pembro, axitinib. I agree with that, but I'm very kind of thinking the data definitely is changing with the high response rates, high CR rates, and we are seeing that in practice with the newer combinations.
But what about anyway, the toxicity of cabozantinib in your experience? Because we have started using cabozantinib in second line, and few of the patients who are not affording 60 mg, maybe at least the hypertension and the palmoplantar disease, that is definitely more than the XZ and lenvatinib, but I have observed. I don't know others' experience in that.
No, I agree with you. 60 is toxic, but the good advantage in this trial was 40 is quite okay, and most of our patients at 40 are doing well. Even lenvatinib, we are quite okay now. We have got sort of adjusted to some regime, so I think that's good. So I think, yes, it will come down to our experience and toxicity management, but all of these give us good responses. So that's the reason why we like these IO-TKI combinations. And I sort of fully agree with Dr. Amit here about the IO being, we should choose our patients very well. If we choose a rapid progressing patients, we have burnt our hands also sometimes in this situation, and it's better to be very careful in choosing our patients for IO. One question I had was for my urology colleagues. If we have a metastatic RCC, and nowadays when we give pembrol and lenvatinib, we have seen amazing responses. All the metastatic sites have disappeared after 6 months, 8 months, just that small primary left. We are tempted to operate to cytoreductive surgery. What are you thinking nowadays? If I have my urology colleagues, what do you operate in your centers?
Hi, Dr. Amit. This is Dr. Rakesh.
Dr. Rakesh. Yeah.
So it is very tempting, I know, but most often when there is no symptomatic issue with the patient, there is no point in operating. So most of us will leave it unless that's the only site, and on continuous follow-up with PET scans, and it shows that that's the only site of residual disease, we might consider in that situation, considering the performance status and all those things of the patient, it can be considered. But you all know that there is no data on that when this patient should be operated. So,
right. So it's a big controversy in clinical practice. So I'm still sending my intermediate risk patients and all those for surgery. And we are still doing it in our center, except for the high risk patients, we are still sending them. And I just don't know whether we are doing right or wrong. That's what keeps coming to our minds.
Dr. Amit, if you operate the patient who is in partial remission and there is a disease, after that you will continue the pembrolizumab only, or you continue still the combination of IO and TKI? So it will be definitely confusion. It's a M1, now it's in CR. So
yes, I agree. But so we say continue the combination at least for some time, and then later try and see which one you are going to withdraw. So but we are still operating. I'm trying to actually follow up our patients and see what happens to them. But yes, I think there are two good trials looking at it exactly, trying to answer this question in the IO era, that if you gave IO-TKI first line, should you operate or not? So I think that will be a very interesting data set.
So do you biopsy these patients prior?
Before starting treatment? Yes.
If there is associated sarcomatoid differentiation,
then all the more for IO-based combinations. We just push them for IO. That's the way we think about it. But though we say IO, but even IO-TKI is good. There should be an IO. That's the main thing, I think, in sarcomatoid. So another question was how...
Dr. Sarupa has also joined she's from ours. She's a senior consultant radiation oncology. She's just joined. She also had the same glitch as you had.
I don't know what it was. This is the first time we had an hour it took. It was so Dr. Swarupa, my question was in the same thing. When you have a patient who responds very well, and you have these small residual diseases, giving SBRT, even if patients are doing well, or would you just reserve it and say when they're progressing, I would just give SBRT? That's the thought which keeps coming, confusing thought in our patients.
So I did not listen to the entire thing. I couldn't listen. So is it about a metastatic, oligometastatic disease you are talking about?
So we started with a metastatic disease, and they show a very tremendously good response to this IO-TKI, and everything melts away, and you have this small residual disease left. Should we kind of radiate them now and continue our IO-TKI, or should we say when they progress we will do it?
See, it's difficult to say actually, because oligometastatic, as a rule, they are treated earlier, right in the beginning. So before you start with the systemic treatment. So, but at this place, it is difficult to really say whether we go ahead. But if you go by the basis of oligometastatic, the local treatment for oligometastatic disease, you should direct your radiation to all the metastatic sites. So going by theoretically, yes, we should. But actually, there's no guidelines, and we really don't know, what we should actually be doing.
Right. So that it always creates a confusion. We think maybe by consolidating with SBRT we may have better responses, but I don't know. It gets confusing.
Yeah, the same we are doing. I wait for 1 year. If there is a very good response to other side and disease is only limited to the kidney, I usually send them for a SBRT. Or in some of the patients, they just want the tumor to be removed. I told that wait, but when they read the PET scan and they see that is the only site of the disease, and so few of the patients are doing. So I wait for at least 1 year. If the disease is very good controlled is the other side of the body, practically metabolic CR, then we may go. We don't know the right way, but I think that what we are practicing here also.
Right.
Amit, one question. Yeah, Amit, one question. You just said, Amit Joshi, you just said CR. With Len and PEM, you have 25% CR, which was unheard of. So would that sway your thought process towards this combination, or would you still go for the PEM-XZ or other combinations? So how much CR would have an impact in your treatment decision?
Yeah, so I think in a long term, if we look see the data, I think the impact of the CR will be there. So I think what the Amit was saying, that gradually we are now realizing how to practice or how to manage with the Pembro Len. So I think, and fortunately, the Len is now available with the Indian brand also. So previously with that, the Pembro XZ, so fortunately both XZ and now Indian brand available. So definitely we, but patients who are doing getting a CR, the only problem with this data that we have to still wait for the long-term follow-up. So I think as the time passes, the more trust on the regime and long-term follow-up there. Now we are changing our practice gradually. So even we have now gradually shifted to PEM plus Len, but definitely achieving a CR will be an important endpoint if we select a regime.
Right. And another thought was, how long do you treat?
Amit, you can ask a couple of more questions before we wrap up. Dr. Chandan Das is also there. And
Dr. Swarupa was saying something.
I wanted to add something, that this radiotherapy, SBRT or hypofractionated radiotherapy, other than the local effect and the abscopal effect, the third effect, it does have a synergistic effect on, or it helps the immunotherapy also. So that can also be a context on the basis of which you can give SBRT even when there is a good response with your systemic treatment and immunotherapy.
Right. I am fully tempted, and we normally nowadays are doing more and more of this. So so I would fully agree with this. Dr. Chandan, how long do you continue treatment? Suppose your patient gets a very good response. You got 6 months and you got very good response. You treated for another 3 months. What do you do? When do you stop in these patients? How are you thinking of it now in practice?
Most of the times I stop because of financial toxicity, because I'm in a center that is matters actually more. So if I have a financial toxicity, I stop that IO thing and continue the TKI. And one of the patients, 1 or 2 patients, they are still continuing the IO. It's almost, I would say, around 18 months. I started from early. So he's still in very good PR, you can say, PR at least. And we'll still continuing with IO with a hypothyroid regime and some hypoadrenal regime. But I'm still continuing.
So I have a thought that I believe.
So I think 2 years. I feel 2 years is the cutoff time. I think I feel I should stop.
I agree. All the clinical trials still talk of 2 years with Pembro at least, but very difficult for our setting in India for our patients. So
it's
I have a thought.
I would say it's impossible.
I keep
continue
thinking,
for 2 years.
You can get very good response initially, and then you can pull off the IO. So what do you think about this? Just giving 8 cycles, 6 cycles, and just pulling it off after getting very good response. You get the response in the first 3 months. Those which are the extremely good responders, and then continue your VEGF TKI. What are your thoughts on these kind of things? Do you do that sometimes? Tempted to do it? Because our patients stop treatment anyway because of cost, but we have got the response.
I think the only thing is that those who achieve a CR within 6 to 8 months, there is some point in stopping the IO in those patients and continuing TKI. So that's what we do. I usually talk to that. We will see the response at 6 months. If there is a very good response, I want to continue personally for 1 year at least in those who are not affording. So if there is a very good response, like a CR after 6 months, I try to convince them to take at least 1 year and then stop IO and continue TKI. But those who still have a persistent disease after 6 months, then it's very difficult to take a call whether to stop at 6 months or 1 year. So some sort of achieving CR may be a hint or maybe an indicator, but I think 1 year may be at least we have to continue if we look to the data of other subsets or other sites.
Yeah, I agree. I agree. Most patients we would try to get to 1 year. We may phase out the doses, but we'll definitely try to get to a year at least.
I think Amit, you can ask the last question.
Yeah.
Yeah.
Sir, I have the last questions. So any combination is preferred for CNS metastasis or all are same? Somebody says cabozantinib is much better.
So I had a case for the question which has a classical patient with a RCC with lung mets and brain mets and presented with hemiplegia and presented with a bedridden status. And I actually had the photographs in this for the case presentation. So I was trying to ask questions for that, what you have asked. So I learned something. What I learned was we sent this patient for surgery for trying to excise that because she was already hemiplegic and symptomatic. She refused the risk of surgery. Then we sent it for radiation. And they said there is already some amount of shift, midline shift present. So with edema may go up. There is a risk involved initially, but we should do it. And the family refused completely. They said, we don't want any risk. So we didn't radiate, we didn't operate. And in that condition, we gave IO with lenvatinib. And in 4 doses, that tumor had become half. She was walking. The tumor in the brain had come half. So I learned something that you use the TKI goes to the brain. I can't say for all the TKIs, but we have already used lenvatinib and we have this patient a year down the line. And now she has progressed in the brain slightly and now she has agreed for SBRT. So there's no problem now for us. We are just we gave SBRT. But I learned it's amazing to see the responses even in the brain with nothing else. And that too, we started with steroids because the steroid was there. So we were worried immuno will work or not work. So it is the TKI effect. So the TKIs do penetrate the brain. We have seen it in our clinical practice. So I would be confident of adding it.
So I think thanks a lot. So within the given constraints, you could zoom in and we could have some fruitful discussion. On behalf of SOGO, I thank all of you as my esteemed faculty. And I would request Dr. Rawal to give the final word. Dr. Rawal, sir.
Thank you, Vineet. It was a great program. Few talks I missed because of the hitch in joining, as many of us had. Because Gagan's talk I could not hear. I heard partial talk of Raghavan, which was on virtual 3D reconstructions. And in partial nephrectomy, a lot of things are going on, especially in robotic partial, where virtual augmented reality is coming in to play, where you can give better, probably results also, and it will be very helpful for the surgeon in a complex RCC when you have a tumor sitting in somewhere in the hilum or on precarious area. Then Dr. Anurag Mehta, as usual, he was fabulous, and we know that there are not many biomarkers which are there in the clinical practice, but definitely PRBM is coming, and there will be more biomarkers in kidney in future. Then Vedans, as usual, he talks very nicely and his very concisely he told us about SBRT, which is great to know that even the SBRT can be given to IVC thrombus where it can recanalize, and especially the patients who are not operable or not fit for surgery, they can definitely have this kind of treatment. Yeah, or else in some other cases it can be tried also in the metastatic setting, as told by Dr. Datta, where the patient is not fit for any other like treatment or maybe the surgery. He can have radiation, SBRT in oligometastatic stage. Rather, he showed the results are better, but they are the equal number of the reports I am sure will be there in favor of surgery, but definitely good to know that SBRT works in oligometastatic disease. Rajiv Rajendranath has told us about adjuvant treatment. STRACT trial he elaborated in detail, and we know this is not in practice. Most of us will not be giving sunitinib as adjuvant treatment, but definitely in future pembrolizumab will come for sarcomatoid and the node positive disease, which are bound to fail always. They don't, this patient actually will almost always have reoccurrence very soon. They fail unless you have some treatment like pembrolizumab coming in this setting. And of course, Amit Rotham has definitely nicely conducted the panel discussion. And there are some controversies which are being there, which will be may or may be solved in the future about the role of surgery in the metastatic setting, which is Vineet is laughing, but don't worry. As I always say, that is the time of nephrectomy, not is the no nephrectomy, is the time of nephrectomy, which has to change. You just cannot offer to a patient who is having high burden disease. Better he should go for a target therapy or maybe the IO. But then that it does have a role in selected group of the patients where actually IO and target therapy should not be given. Like I was telling an example, that the many time in the practical, in clinical setting, we do have a big tumor with a small metastasis. Rather, in an elderly patient, big tumor with a small metastasis, if Amit may be knowing, the Dr. P.B. Desai always used to show a slide that don't treat a small metastatic disease in elderly patient. You just remove a primary and leave the patient off, because he'll be much, much better rather than with the treatment. Amit knows that thing. So with that, I'll say thank you all. It was a great webinar and well conducted by Vineet. Thank you.
Thank you very much, sir. And we'll try to control the glitch next time. I hope it does not work.
Yeah, we'll do that.
Nevertheless, we were able to salvage thanks to Amit to shoulder it.
Yeah.
And I think I thank all the panelists and the faculty for joining us. And we'll close the session. Thank you so much.
Thank you. Bye-bye.
Please take
Good
care.
night.
Good night.
Thank you, everybody.
Thank you. Bye.